sits in APLAR Congress Scientific Committee, Center of Excellence Scientific Committee, Scleroderma Myositis Group Committee member, and also Malaysian Society of Rheumatology Committee member, and also advisory boards and scientific member of many other autoimmune-related international organizations. Professor Dr. Raja Jasmin Begum is active in doing researches and clinical trial, especially in autoimmune disease, and has published many publications on it. Besides being speakers in many international conferences and congress, she is also active in giving public speaking and organizing events to increase the awareness of autoimmune disease in community. Dr. Raja Jasmin will share about the clinical relevance of autoantibodies in rheumatoid diseases. Question for Professor Dr. Raja Jasmin Begum can be text in the chat room. Please, Professor Dr. Raja Jasmin Begum, the next 30 minutes, the audience is yours. Thank you.
Thank you, Dr. Sian, for the kind introduction. So first, let me share my screen. Okay, a very good morning to everyone. I'm very delighted to give you all this talk today. Firstly, I would like to thank the organizing committee of IACC and Euroimmun and Meditama for inviting me to give this talk today on the clinical relevance of autoantibodies in rheumatic diseases. So I understand that most of you, the participants, consist of general practitioners, pathologists, and also those who are working in the laboratory setting. So therefore, I've organized the contents of my talk in a way that you all will have a better understanding of the relevance of autoantibodies in rheumatic diseases. So here are some pictures to show you some of the famous celebrities who have had autoimmune diseases or still are suffering from this condition. I'm sure you all know who is this. This is Selena Gomez, and this is the Queen of R&B, Toni Braxton, who suffers from lupus with kidney involvement. This is the tennis Wimbledon champion, Venus Williams. She has Sjogren's. I'm sure you all know who's this. This is Kim Kardashian. She has psoriasis. This is Dr. Christian Bernard, a South African heart surgeon who performed the world's first human-to-human transplant. And he had rheumatoid arthritis. This is the French artist in the 19th century, Pierre-Auguste Renoir, and his career as a painter came to an end when he had disabling rheumatoid arthritis. So what is the role of immune system? So it is to keep our body healthy by destroying what perceives to be non-self. So if you see on the left here, this is the normal immune system. When an invader like virus enters the body, the immune cells called lymphocytes create antibodies to fight against this invader. But when autoimmune disease happens, the immune system targets the self-tissue, and this causes immune dysregulation and starts to attack your own cells, and the normal body cells become altered, and this can cause tissue or organ inflammation and injury. So the exact cause of autoimmune diseases are not known, but there are several hypotheses and postulations to suggest that genetic factors, predisposition together with some other risk factors can contribute to the development of autoimmune disease. So that's why probably autoimmune disease is more common in the females due to the hormonal factors. This schematic diagram shows what happens inside the body in the cellular level in autoimmunity and how the autoantibodies are produced. So basically, there's a good cooperation between the B cells and the T cells as a hallmark of successful immune function. So when there's genetic predisposition together with some triggers, so the immune system, which consists of the innate and the adaptive immune system, basically they lose their normal orchestral coordination, and this can trigger autoimmunity. We have the dendritic cells here that stimulate the T cells and also the B cells to produce autoantibodies. So I'll be introducing systemic rheumatic diseases. So it is unusual to diagnose systemic rheumatic diseases just based on a single pathognomonic clinical sign or finding, since systemic rheumatic disease frequently involve multiple body parts and reveal a rich clinical symptomology. So this is opposed to the organ-specific autoimmune disease, which just targets one single organ, where these autoantibodies in rheumatic diseases may be produced against many different cells groups. So this is where the detection of sensitive or specific autoimmune antibodies in the sera of suspected patients is useful to justify the presence or absence of the disease. A little bit on the cause of the disease. Basically, there's no cure for autoimmune or rheumatic disease, but the patients can run the course of disease activity, and if it's not treated properly, this can lead to disease damage. Here is the systemic rheumatic disease which has a wide spectrum of clinical utility. We can see that some autoimmune diseases are driven by the innate immune pathway, where they hardly produce autoantibodies or don't produce autoantibodies. Hence, it is termed seronegative, and the examples are the ones highlighted in red. Whereas the others are driven by the adaptive immune pathway, which produces autoantibodies, and these are the ones highlighted in purple. So when there is a clinical case of a positive autoantibody, we need to make a clinical judgment whether, number one, if the autoantibodies are pathogenic or biomarker of an autoimmune disease. Number two, if it's a risk or for pre-disease or subclinical relevance. And number three, whether it has a secondary effect or byproduct of non-autoimmune diseases. And some of the examples are given here with uncertainty of this clinical relevance of these autoantibodies in these conditions. This is where the history, physical examination, and supportive investigations are important to determine whether they are indeed a biomarker for disease diagnosis. So autoantibodies can precede the onset of rheumatic diseases by many years. So when there is direct predisposition together with immune dysregulation, there may be subclinical production of autoantibodies. And when there are certain triggers, this can cause or promote inflammation cascade with cytokine production and later on lead to onset of clinical disease. Moving on to antinuclear antibody or ANA, a little bit on the history. It was discovered in 1957 in the sera of lupus patients. So antinuclear antibody is a useful screening tool to diagnose ANA-associated rheumatic disease. And it can further specify the diagnosis with determination of disease-specific autoantibodies such as ENA or MSA. It can also determine an impending disease in an asymptomatic individual and also establish appropriate monitoring and prognosis in some rheumatic diseases as mentioned here. ANA is not for monitoring of disease activity. The high titers of ANA do not always show higher disease activity and severity. And ANA is highly sensitive, but it's not specific, as it can present in 20% of healthy patients and also in other situations and non-rheumatic diseases. So with the advent of indirect immunofluorescence testing on the HEP2 cells as a standard method of detection for ANA, it was possible to detect the autoantibodies against a range of different target antigens. Here we can have several patterns such as homogeneous, diffuse, speckled, nuclear, centromere, peripheral or rim, and cytoplasmic. And I understand that the cytoplasmic pattern can be difficult to interpret. Again, here are the patterns of positive ANA indirect immunofluorescence. We have homogeneous pattern, speckled, nuclear dots, nucleolar, centromeres, nuclear membranes, cytoplasmic, or negative and unspecific results. So the ANA titer in SLE, so does it really matter? So if you go according to the updated Lupus 2019 American and European classification, a cutoff point of ANA titer of at least 1 in 80 is needed to be included in the classification criteria. So the lower the titer of ANA, the lower is the predictive value for SLE. And the diagnosis depends on the clinical manifestations. This table shows us the sensitivity and specificity of ANA in connective tissue diseases. So we have lupus and scleroderma, which shows high sensitivity of ANA, but low specificity. And the same goes to conditions like autoimmune hepatitis and primary autoimmune cholangitis. Whereas some of the examples of conditions with low sensitivity and low specificity of ANA include Sjögren's, myositis, Raynaud's, and rheumatoid arthritis. Here is the algorithm of ENA and specific antibody testing in the diagnosis of rheumatic diseases, which can be useful in the primary care setting and also for the GPs whom they are seeing patients whom they suspect to have rheumatic diseases. But there are several guidelines to be considered. Number one, ENA is not recommended to evaluate conditions like fatigue, back pain, or other musculoskeletal pain unless it's accompanied by one or more clinical features of connective tissue disease. Number two, ENA should only be ordered once and it should not be repeated if there's positive ENA. And number three, negative ENAs needs to be repeated only if there's a strong suspicion of an evolving connective tissue disease or a change in the patient's illness, suggesting that the diagnosis should be revised. And why is this so? This is a retrospective study done in the US investigating the clinical utility of positive ENA outside rheumatology testing. So a total of 232 patients were referred for positive ENA tests, and most of the referrals came from the primary care, and the common reason for ENA testing was a widespread pain such as knee pain, hip pain, chronic headache, and also back pain. And it is found that more than 90% of these patients do not have evidence of ENA-associated rheumatic diseases. The other reason could be the cost associated with each category of investigations. This graph shows the total cost of associated with appropriate tests and total cost associated with inappropriate tests. And the total cost associated with all these investigations came up to 33,000 USD, and that's a lot, and of which 49% of it were inappropriate or unnecessary. And the highest proportion, believe me, it was attributable to the inappropriate ENA testing, which was seen in 25% of the patients, in particular repeat ENA, which was seen in 17% of the patients. Here are some of the pitfalls, those with ENA positive, given the significance of its positivity, especially the general population, it should not be overinterpreted. And high titers of fine speckled ENA pattern can also occur in the healthy individuals owing to the presence of anti-DFS70 antibodies. Whereas in the ENA negative group, given the high sensitivity of indirect immunofluorescence of up to 90%, the remaining 10% might miss the presence of certain antibodies due to the low abundance of the antigen or because of the fixation method. But if you're still highly suspicious of connective tissue disease, you will need to do an alternative diagnostic assay or send for specific antigen to confirm the diagnosis. So moving on to the first rheumatic disease, which I'm going to talk to you about, systemic lupus erythematosus, or SLE. So lupus is a Latin word for wolf because the disease is said to cause scarring rashes that looks like wolf bites or because it devours the affected part. So autoimmune is an autoimmune disease that can affect multi-system and organ. So this is why lupus is often called a systemic autoimmune disease because its effects are system-wide. It's more common in the females in the age childbearing years. This slide shows the various symptoms of lupus affecting the various organs and system. And there's also an entity called antiphospholipid syndrome, where patients can have abnormal blood clotting resulting in thrombosis or embolism, or they can have recurrent miscarriages with the presence of antiphospholipid antibodies. This is a lady with butterfly mala rash. This is a case of Raynaud's where a patient can have triphasic color change from pale to blue to pink when there's exposure to cold. This is a case of livedo reticularis, pleural effusion, discoid rash, inflammatory arthritis, and mouth ulcer. So what are the antibodies that are useful in the diagnosis of SLE? We have anti-double-stranded DNA antibody, which is a hallmark for the diagnostic criteria for SLE. It gives information about the disease activity, therefore it can be performed in intervals, whether it's 3 to 4 monthly, 6 monthly, or yearly. So the higher the value of double-stranded DNA, the higher the chance of the patient having a risk of exacerbation. And it also suggests that the disease activity is still not controlled. It is specific for lupus, and it can also predict kidney involvement. But one of the pitfalls is it can be positive in a small percentage in other conditions. Then we have anti-Smith antibodies, and it is found in quarter of SLE patients. It is low sensitivity, but high specificity. Earlier, I mentioned about antiphospholipid syndrome, and these are the antiphospholipid antibodies that are easily available in the labs. This is lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein. There are APL positive patients where up to 5% of the patients can be asymptomatic and can also be seen in other conditions such as infection, malignancy, and chronic liver disease. But there are also an entity called a seronegative antiphospholipid syndrome where the patients are negative for APL antibodies. This is probably due to the antibody consumption during the acute thrombotic episode or certain antibodies to the heterogeneous antiphospholipid family, which has not been identified or still under research. Moving on to drug-induced lupus. This is a condition where lupus symptoms actually is started when there's administration of certain drugs, and the symptoms resolve after suspension of the drug. In this case, ANA and ENA can be negative, and also dsDNA can be negative, and antihistone antibodies are very specific, and it is seen in 95% of this condition. Moving on to another condition called mixed connective tissue disease, we use the laboratory autoantibody anti-RNP or ribonuclear protein, which is one of the diagnostic hallmark criteria for mixed connective tissue disease. It is found in low titers in scleroderma and SLE, but it's not specific. So patients can have symptoms of and signs of a combination of disorders, primarily lupus, scleroderma, myositis, and Sjögren's. And some of the clinical manifestations are Raynaud's, inflammatory myositis, and inflammatory arthritis and interstitial lung disease. And this is not too different from another condition called undifferentiated connective tissue disease, where symptoms and lab test results that indicate a connective tissue disease, such as Sjögren's, lupus, scleroderma, or myositis, but they do not meet enough such characteristics or do not fulfill the criteria of each of these diseases to indicate a diagnosis for a well-defined connective tissue disease. Therefore, most of the time they present as a mild disease or with very subtle symptoms. So ANA is seen in 100% with small proportion positive for other antibodies, and the most prevalent manifestations are what is listed here. Now moving on to scleroderma or systemic sclerosis. The word sclera is derived from the word hard. It's derived from the Greek word sclera for hard and the derma for skin. It has three main pathogenic components, which are cellular immunological abnormalities, obliteration of the microvascular structure, and tissue fibrosis, which can involve either the skin and also the organ base, such as the lung, heart, or the GI system. So we classify the subsets of scleroderma to limited and diffuse, and this is classified according to the extent of skin involvement, such as skin tightening and hardening. The majority of the patients in the limited subset have anticentromere positive, whereas those in the diffuse subset have anti-SCL positive. And there's also a wide variety range of scleroderma-specific autoantibodies, which serves as a clinical utility or biomarker to predict certain organ manifestations in scleroderma. Here I've summarized the symptoms and signs and the clinical manifestations that can happen in scleroderma. Here we have lung fibrosis or interstitial lung disease, and the majority of the patients who have this are anti-SCL70 positive. Patients who have pulmonary arterial hypertension, it can be seen in about 20% of the those who have anticentromere, and anticentromere is also seen in those who have telangiectasia. And Those who have musculoskeletal problems like myositis, they can be positive for anti-PMSCL70 or PMSCL100. And patients who have anti-RNA polymerase III positive, they are in the risk of developing scleroderma renal crisis or kidney involvement. Here are some of the pictures showing the result of skin tightening that happens in a patient. And you can see that there's a small mouth because of the skin tightenings, and thinning of the lips and puckering of the mouth. This is where the skin tightening in the chest and also the forearm and the hands. Here is a typical Scleroderma Faces where the patient can have small mouth, pinched nose, as well as telangiectasia. So as I mentioned earlier, the patients can have poor circulation because of the obliteration of the microvasculature. So they can have symptoms like Raynaud's and also poor healing, especially the digital ulcers. Some of the patients, especially in the cold climate countries or during winter, they can develop dry gangrene, and some of them they can complicate into autoamputation. We have also patients who have deposition of calcinosis subcutaneously. Moving on to Strogan syndrome. So Strogan syndrome can either occur on its own as primary or secondary to other connective tissue disease. The immune cells basically attacks the body's tear or salivary gland, mainly causing dry eyes and dry mouth. And occasionally it can affect the other organs. Here is a picture of a dry mouth, dry eyes, vasculitic rash, and interstitial lung disease. So the anti-Rho and anti-La, which is SSA and SSB, so they are the lab tests for diagnostic and classification criteria for Strogan syndrome. So SSB generally shows parallelism to SSA. So these antibodies are mostly detected in those with primary Strogan syndrome, but less frequently in secondary Strogan syndrome. It's also seen in some patients with lupus. Therefore, if we have high suspicion of a patient to have lupus or Strogan's, especially when the ANA test is negative, it is advisable to order for SSA and SSB. SSA and SSB is also associated with neonatal lupus and congenital heart block, where seen in up to 5% of all seropositive mothers. Therefore, it's advisable to order this test in mothers who have neonatal lupus and congenital heart block, and also SLE patients who are planning to get pregnant. Here's a picture of a baby with neonatal lupus and the indirect immunofluorescence staining of hepatocells cells exhibiting the nuclear fine speckle pattern of SSA and SSB. Moving on to inflammatory myositis. These are distinct clinical subset of myositis that can be defined by unique clinical phenotypes and associated with autoantibody profiles suggesting that there's a heterogeneity of disease pathophysiology. So the patients can have inflammation of the larger muscle groups and mostly the proximal muscles. Polymyositis and dermatomyositis are included in the systemic rheumatic disease where they can have inflammation of the muscles. And basically these two conditions are rather the same, but in dermatomyositis, in addition to the muscle inflammations, they have skin manifestations which are pathognomonic to dermatomyositis. And 10% of these patients who have dermatomyositis have underlying cancer. So the clinical symptoms include weakness of the proximal muscles. Later, it may affect also the distal muscles, which can affect their daily chores and activity of their daily living. Even simple tasks like getting up from a squatting position or from a chair or even climbing up the staircase. Some of the extramuscular manifestations include Raynaud's, arthritis, GI involvement such as dysphagia, cardiac arrhythmias, and interstitial lung disease. Here are some of the pathognomonic skin signs for dermatomyositis. Here we have Gottron's papules. You can see rashes at the extensor surface of the joints. Heliotrope rash, it means like a purplish flower is seen around the eye. And shawl sign is at the distribution of the shawl area, especially at the photosensitivity area, which is exposed to sun. This is mechanics hand where patients can have a thickening hyperkeratotic dry skin at the fingers, and periangular erythema is seen when there's dilated blood vessels at the nail bed. And lung involvement, patients can have interstitial lung disease or lung fibrosis. So we order creatine kinase as is the most sensitive muscle enzyme, especially the muscle injuries. In cases like polymyositis and dermatomyositis, the creatine kinase can be raised in hundreds or thousands or even in tens of thousands. LDH, AST, and ALT often correlate very well with the CK levels. ANE antibodies is seen in up to 80% positive in polymyositis and dermatomyositis. Sorry, I'm testing. I'll be having some interruptions here.
Please mute your mic.
Okay, and anti-myositis specific antibodies are also ordered. And beside this autoantibodies, lab tests, and CKs, we also perform muscle biopsy and electromyogram to confirm the diagnosis of inflammatory myositis. So myositis-specific autoantibodies are highly specific for myositis, and it can be, and there's a striking association between these individual MSAs and the distinct clinical phenotypes, makes MSAs as the excellent tool for subsetting the patients and also to predict the disease outcome and also the causes. And here we have the unique entity called Antisynthesis Syndrome from the inflammatory myositis group, and it is autoimmune disease characterized by these autoantibodies against ARS and against many of the TRN syntheses with these clinical features that include myopathy, interstitial lung disease, non-erosive arthritis, fever, Raynaud's phenomenon, and mechanics hands. And among these ARS antibodies, Jo1 antibody is the most prevalent. And in this study, it shows that patients who are positive for Jo1 antibody, they have a better 10-year survival rate compared to those with non-Jo1 positive patients. This table shows the clinical association with the anti-ARS antibodies, and most ARS appears as cytoplasmic pattern in the immunofluorescent, indirect immunofluorescence staining in the ANA. And sometimes this cytoplasmic ANA may be reported as negative. We also have the myositis-associated autoantibodies, and this is found in myositis and also in other connective tissue diseases. For example, the case I mentioned earlier, where in scleroderma patients, we can have PM-SCL75 and PM-SCL100. So, a myositis-associated autoantibody suggests that overlap syndrome is the other possible condition. So here is a spectrum of inflammatory myositis disease with various clinical presentation. We have antisynthesis syndrome, as I mentioned earlier. We have connective tissue disease overlap, some inflammatory myositis, which are more prone for skin and malignancy. And there's also a group of patients in this inflammatory myositis group who do not have muscle involvement, ironically. And the term called is amyopathic. And 80% of these patients are positive for MDA5. Moving on to rheumatoid arthritis. So rheumatoid arthritis is the most common inflammatory arthritis seen in adults. So patients can also have constitutional symptoms such as feeling feverish, early morning stiffness of the joints lasting for more than an hour, feeling fatigue. But what is prominent is the inflammation of the joints, especially those affecting the small joints of the hands, and it can also affect any other joints in the body. So here we have patients with inflammation of the joints affecting the small joints of the hands, the ankle and the feet, and the knees. And in the x-rays, if you could see, this is the advanced stage. They can be seen as erosive lesions and loss of cartilage. And this can also lead to loss of alignment and shape and damage and deformity of the joints. RA patients can also have extra-articular features of RA, for example, inflammation of the sclera called scleritis, foot drop secondary to mononeuritis multiplex, subcutaneous nodules, Baker cysts, and lung nodules. So there's no single lab or imaging test that can diagnose rheumatoid arthritis, but physician needs to review the clinical assessment of the history, perform a clinical examination, and order a combination of imaging and lab tests. And what we commonly order is the rheumatoid factor and anticyclic citrullinated peptide, or Anti-Ccp. So the presence of rheumatoid factor is not specific for rheumatoid arthritis and does not established in the diagnosis of RA. So therefore, you can see that it's only seen in about 60 to 70% of patients with rheumatoid arthritis. So because it's highly sensitive and not specific, it's seen in up to 20% of healthy individuals and in other connective tissue diseases, infections, and cancers. So this is opposed to Anti-Ccp, which is low sensitivity but high specificity, and therefore it's only seen in 30 to 60% of rheumatoid arthritis patients. Both rheumatoid factor and Anti-Ccp, they precede the onset of disease symptoms by years and predict a more severe disease course. And in particular, Anti-Ccp, it can cause a more severe joint destruction and erosions. Here are the difference between seropositive and seronegative RA. Basically, in seropositive RA, there are predisposition by the genetic risk factors such as shared epitope and also the risk factor for smoking. Patients with seropositive RA have a more erosive pattern and more damaging disease, and they are also more prone for extra-articular manifestations. Here is a study that shows that patients with seropositive rheumatoid arthritis have a more erosive or more increased number of erosions compared to patients with seronegative rheumatoid arthritis. And lastly, moving on to ANCA vasculitis. So it is a spectrum of systemic necrotizing vasculitis predominantly affecting the small vessels of the diverse organs. Here is the Chapel Hill classification of vasculitis. We have the large vessels and vasculitis which do not produce autoantibodies, hence termed seronegative. Whereas on the right here, we have the small vessel vasculitis with some conditions that produce autoantibodies. And here I'm going to focus on ANCA-associated small vessel vasculitis. We have microscopic polyangiitis, granulomatosis with polyangiitis or vaginous, and eosinophilic granulomatosis with polyangiitis, or also known as Church-Strauss. And these are the clinical manifestations of ANCA-associated vasculitis, which can affect various organs, and in particular, vaginous and Church-Strauss usually affect the respiratory tract, whereas the microscopic polyangiitis usually affects the kidney. However, these conditions can potentially affect any organs. And coming to the autoantibodies, while ANCAs are directly involved in the pathogenesis of the disease, ANCA-associated vasculitis, they are featured by lack of the immune deposits termed pauci-immune. So when we suspect a patient to have ANCA-associated vasculitis, need to order for C-ANCA or P-ANCA, and this can be done with immunofluorescence staining testing. You can see that cytoplasm and the perinuclear has been highlighted in the immunofluorescence respectively. And then we can further test them by using the antigen-specific ELISA by testing for proteinase 3 and anti-myeloperoxidase respectively. And in patients with C-ANCA or PR3, mostly they consist of vaginous, whereas in P-ANCA and MPO, mostly they consist of Church-Strauss, microscopic polyangiitis, or pauci-immune glomerulonephritis. However, up to 10% of the patients with small vessel vasculitis can have clinical test negative for ANCA. And conversely, the false positive results can occur also in the general population, other autoimmune conditions like SLE, and other conditions like malignancy, infection, and also certain drugs. And lastly, apart from systemic rheumatic disease, there are many other autoantibodies that are specific to other organ-specific autoimmune diseases. So in summary, rheumatic disease diagnosis is mainly based on the clinical laboratory and radiological parameters. ANA is valuable in the diagnosis and prognosis prediction. Specific autoantibodies serves as a biomarker to predict diagnosis, clinical phenotypes, prognosis, and treatment decision making. The active involvement of disease-specific autoantibodies is a pathogenic process is beyond the simple association with the disease. And lastly, a clinician should rationally use the laboratory findings as a supplementary diagnostic method. With this, I thank you and I'm happy to take in questions.
Thank you, Professor Dr. Raji Jasmin, for your very immune disease is a complex disease, and using the marker wisely is very, very important. So let's start with our question and answer session. While waiting for the question sent to me, there is one question.
All right.
A is a sensitive marker for some autoimmune disease, but have lower sensitivity for other autoimmune. What other tests do you suggest to improve the sensitivity, the specificity of an ANA? Is it combining with any profile or with mixture of many antigen help increasing sensitivity?
Okay,
and you suggest to, and when do you suggest to combine with the other platform? I mean, ANA, IF with ANA solid phase.
Okay, so the ENA is quite rather specific. So we do sometimes we do send ANA and ANA together simultaneously when we strongly suspect a patient to have a certain rheumatic disease. So again, as I mentioned earlier, just the lab test alone is not important, but we have to use it in a setting of clinical utility where we have to evaluate based on the history, the clinical examination, the manifestation to come to the diagnosis. Because as I mentioned earlier, sometimes this positive ENA or such as anti-Rho or anti-La can be also positive in the general population. So we have to use our interpretation widely.
Thank you, Doctor.
Wisely, sorry. Yeah.
Thank you. There is another question from the audience. Professor, is it better to test rheumatoid factor or Anti-Ccp from serum or from synovial fluid? It is from Dr. Hantoro Gunawan.
Okay, that is a good question. So basically, we don't usually perform this unless this is for research purpose. This is when I think it can be done, but usually this is not. The clinical manifestations of rheumatoid arthritis is again based on the physician's evaluation by the clinical presentation of rheumatoid arthritis. Even though if the patient is negative for rheumatoid factor or Anti-Ccp, doesn't mean you have to, aspirate the synovial fluid and test them. No. So this is more for probably for research based. But I guess sometimes when there is, in a very rare occasion, when the patients can present in a very odd way where they have persistent just as a monoarthritis or so of a single joint, sometimes you would like to aspirate and send for other conditions, other investigations such as biopsy of the synovium, or aspirate this to look for other conditions such as infection or such as malignancy and so on to confirm the diagnosis.
Thank you. There is another question. Do we have to test the Anti-Ccp and rheumatoid factor concurrently since they have the impact on severity and also the prognosis?
Yes, this is if it's easily available in your lab, so why not? So some patients can have a negative rheumatoid factor, but positive anti-CCP, because anti-CCP antibody can be detected in early rheumatoid arthritis as early as 6 weeks. And it can also predict the occurrence of rheumatoid arthritis also in the future, especially those with strong family history of rheumatoid arthritis, for example. Yes, I personally do send this test simultaneously.
Thank you. From Dr. Jessica Santoso, how we should interpret ANA DNA and anti-DS DNA if it is in borderline value, but the patient didn't have any symptoms?
Okay, that is a very good question. Yes, we do get quite a bit of referrals from the general practitioner or from other specialties such as orthopedics and so on. So again, double-stranded DNA and ENA, it can also be present in other conditions or in other, even in the general population. So we have to interpret our results wisely and as you mentioned, if the patient is asymptomatic, then probably I wouldn't be too bothered. But if, let's say, if it's really high and there's some of the risk factors such as family history of autoimmune disease, I would actually mention to them if, yeah, we should observe you for now. But if you have symptoms such as joint pains or photosensitivity rash, hair loss, and feeling not well, you can come back to us and we should re-evaluate your condition.
Thank you. I think there are many questions, but I think this is the last one due to the time constraint. How far is the use of the quantitative autoantibody in the diagnosis and monitoring of autoimmune disease?
The specific, or the quantitative
yes.
autoantibodies such as, I guess, such as myositis antibodies and also scleroderma autoantibodies. So I find it quite useful. So not all the hospitals have these facilities. So some they send to private lab, but we are glad that certain labs, some companies like Euroimmun, they produce this. And I find it to be quite useful because in some of my patients, for example, in scleroderma, I find them to have negative anticentromere, negative SCL70, and even negative ENA. So what do I do? But I strongly suspect that they have scleroderma. So I do send for scleroderma autoantibodies, and I found that some are positive for even the centromere A and centromere B, even though the centromere in the ANA is negative. Or even if I see them with the muscle involvement, then I see that, oh, they're positive for PMSCL and so on. So the same thing happens in myositis because what commonly available in our lab is JO1. But when we do the myositis-specific autoantibodies, this can turn out to be positive and quite important in terms of clinical relevance.
Thank you. Thank you, Professor. We are really expecting you to come again next time.
Thank you. And I really enjoyed giving this talk. And thank you for all the questions.
Thank you. So I think we will go to the next speaker. For the next speaker, we have Mr. Tiong, Master of Science, who will present about diagnostic of systemic rheumatoid disease. Mr. Tiong is a product manager of Euroimmun Southeast Asia. He graduated with Master of Science from Nanyang Technological University and have co-published research articles in peer-reviewed journal. Mr. was previously medical laboratory scientist in SGH, Central Tuberculosis Laboratory. His experience includes development of molecular assay and working with highly pathogenic organisms in BSL-3 labs. Mr. the next 30 minutes is yours. Thank you.
Okay, thank you, Dr. Tjan, for the kind introduction, and thank you, Prof. Jasmin, for the lovely slides. I think it's a very good way that we can bridge this into a more laboratory clinical investigation slides. So I will continue on the presentation from Professor Jasmin on the diagnosis of systemic rheumatic disease. So in my focus, I'm focusing more on the laboratory diagnosis portion of it. And from there on, let's continue with the presentation. So Euroimmun is an innovative short introduction about Euroimmun. Euroimmun is an innovative company whereby we do hold multiple patents, which includes our title pin technique as well as our biochip technology. Not only are we about autoimmune diagnosis, we do have kits that are detecting for other infectious disease parameters, so on and so forth. At the same time, we do understand that globally in laboratories, automations are the next thing to come. So we do have our automation suites available for all kinds of diagnostic. And in the current era of SARS pandemic, Euroimmun also do have a comprehensive testing portfolio of SARS-CoV-2 related diagnostic products. So in Euroimmun, we are all-in-one solution whereby we do have reagents, automation, software, and support to provide support for the laboratory diagnosis such that a better quality results can help in the patient care. So in that laboratory diagnosis methodology, Euroimmun specializes in IFT, ELISA, immunoblot, microarray, and as well as the real-time PCR methodology for scientific investigation. So without further ado, let me just go on to today's agenda. So in today's agenda, what I'll be talking on will be the current recommended diagnostic algorithm and challenges in rheumatic disease testing, automation in ANA diagnostics, confirmatory tests, how on with Euroimmun, and as well as ways to secure and make sure that laboratories can have a better quality through the provision of external quality assessment as well as diagnostic support. So as we move into the autoimmune world, so one concept that we have to really understand would be ANA. ANA are basically autoantibodies that bind to different antigens of the immune cells. So these are literally components or antigens that's located in the cells itself. Like what Professor Jasmin mentioned previously in her talk, ANA can be found in many disorders. Some of the common disorders that we describe are autoimmunity. However, it can also be found in patients with cancer as well as infections. There are many kinds of ANA factors available. So what I've shown here is that these are some commonly described autoantibody antibody that is being reported in the laboratories globally currently. And more often, ANA, like what was mentioned previously, is commonly used in the diagnosis of autoimmune disorder. So some of the common systemic rheumatic diseases is listed here, such as your SLE, your Strogan Syndrome, your mixed connective tissue disease, myositis, as well as a scleroderma disease. We have known from publications that ANA has a high prevalence in autoimmune disease. As you can see in this table, there's a high percentage of ANA prevalence in your systemic rheumatological disease, especially where you can see in SLE, so on and so forth. These percentages are really, really high. So one thing to take note is that there are difficulties in diagnosis of autoimmune disease. This is because the patients are initially presented with very non-specific symptoms such as fatigue, joint pain, muscle pain, fever, and even weight changes. So some of these symptoms may often flare and also result in symptoms. And patients many a times not only just have one autoimmune disease, but they may have severe underlying autoimmune disease happening at one time. So the key to take home from this is that early diagnosis is the key in autoimmune disease testing. So to talk about autoimmune disease testing, we first have to talk about the ANA task force recommendation. So a recommendation that was posted in 2008 by the American College of Rheumatology, they did come to a consensus and recommended that ANA testing should be performed on HEP2 cells. So apart from the testing of HEP2 cells, during reporting, the IF, the immunofluorescence titer should also be given such information is helpful for the diagnosis on the clinician side. And the third point is that the pattern observed from the ANA screening ANA test should also be described along with all these other factors as mentioned previously. So how does HEP2 cell help in ANA testing, or rather how do the laboratory conduct these such tests? Firstly, let me introduce to you our biochip technology. What happens here is that HEP2 cells or whatever or tissues are basically fixed onto a slide. These slides are then cut into smaller pieces, and subsequently small biochips, is what we call, are then placed into our small fields of microscopy here, and everything will then be based off this microscope slides. Using this technology, it actually helps in standardization of IFA because we do have a batch production whereby there's a more equal quality that's being maintained. And using the technology of biochip, we actually help by combining many different substrates into one single test. So this allows simultaneous screening and confirmation at the same time using one biochip. Euroimmun is a company whereby we have more than 300 substrates that are available for screening. So I did mention previously that the patterns should be described in the reporting of ANA testing. However, before 2014, there were many kinds of description of how ANA was reported. So in 2014, there was an international consensus group that was formed, or what we know as ICAP. They came together and standardized the way how ANA reporting should be performed. So through that, ANApatterns.org was conceived. So for more information on ANA reporting or how in this group, you may visit this website called ANApatterns.org, where the different ANA patterns are being written down and published in this website. Euroimmun is not only a company that helps diagnostic, but at the same time, we do follow the guidelines and help in order to help laboratory with their reporting of the results. So from there, Euroimmun actually, using Euroimmun's HEP2 cells, we are actually able to differentiate the different kind of ANA pattern that's available, and at the same time, show it based on ICAP's presentation of the different ICAP the different ICAP categories for HEP2 cells that's available. Okay, so let me just zoom into some common patterns and associated disease with the ANA patterns as observed. So we do have 4 different kind of patterns that's available and also in this table, what I've shown is the HEP2 cell images, known target antigens, as well as associated rheumatic disease. So for the negative patterns, we can say that from a laboratory diagnostic point of view, the chance of having rheumatic disease is low from this, hence it's negative. For the ICAP's AC1 pattern, or what we know as nuclear homogeneous pattern, the common known antigens are normally your double-stranded DNA, single-stranded DNA, nucleosome, and histones. All these patterns, all these non-targeted antigens do have high association in the development of SLE patients. The next pattern that I would like to highlight will be your AC2 or the densely fine speckled pattern. In the densely fine speckled pattern, known antigen the known antigen is DFS70, and this is known to have association with many autoimmune diseases such as SLE, Strogan Syndrome, Scleroderma, and at the same time myositis. The last pattern to highlight here will be your nuclear pattern, which is the fine speckled. So in the AC4 pattern, the commonly known targeted antigen will include your SSA, SSB, your CoO, Me2, T1 beta, as well as your T1 gamma. These known antigens that are associated with the AC4 pattern are commonly described in the SLE patients, the Strogan Syndrome, systemic scleroderma, as well as the myositis. So from position paper, the task force recommendation, we do know that ANA testing is important for autoimmune testing because of the high sensitivity of certain markers in certain diseases. However, if we were to look through publications, there are some diseases that may result in a decrease in sensitivity if we were to just base our diagnosis on ANA-IFT alone. As shown in this diagram here, if we were to just base on ANA-IFT, we do have a decrease in diagnostic sensitivity for our myositis, our Strogan Syndrome, and other diseases. So, in summary, how we look at challenges is that, to bring upon the point is that we do know that gold standard of ANA detection is via IFT, and then the IFT must be done on HEP2 cells that results in unique patterns due to the presence of autoimmune antibodies. Last point from the task force recommendations that reporting of ANA patterns should also be referenced based on ICAP or standardization. However, we do know that there are challenges behind all these techniques. In short, we do see diagnostic difficulties and as well as infrastructure challenges that can impede the right results from being reported. Hence, I would like to introduce to all of you all how we can go about overcoming these barriers that are involved in the diagnostic challenges. The first point that I would like to make would be overcoming this infrastructure limitation with automation. Let me introduce to you our Euroimmun's Euro pattern. So, in a laboratory whereby sample preparation and incubation of samples are done in slides, these are then loaded onto our Euro pattern, our automation here, which will help in the recording of IFT results and subsequently report an analysis of results. So the Euro pattern is a microscope that can hold up to 500 different films with 2 different cameras. It does have different objectives available, and as this is a image capturing device, we have outfitted it with shock absorbing feed such that we are able to capture the most accurate image from the IFT slides. And at the same time, we have outfitted it with manual controls should there be a secondary read for the operator to take a closer look at the images. And all this image can be acquisition time for per well is at 13 seconds. So using the Euro pattern actually provides unmatched variety of different patterns which is recognized automatically. The software for pattern recognition is based on 115,000 verified reference pictures that can help you call out the different observed patterns in your patient sample. The Euro pattern then helps suggest to laboratory technician the observed patterns in the patient serum, and at the same time, it can call out mixed pattern, which is difficult for laboratory technicians to identify. So the Euro patterns are able to call out these following patterns, such as your homogeneous, granular, nuclear dots, centromeres, nuclear membranes, cytoplasmic patterns, as well as meiosis patterns. And these are just for some of the patterns that's recognized by our software for the ANA recognition. So let me just break down to you how Euro pattern actually understands and call out the different observed pattern that is being seen. From a scientific point of view, we do know that a phenomenon called photobleaching do occur when cells are exposed to too much of light at a certain wavelength. Hence, in the Euro pattern, focusing is always done in white light such that it prevents the phenomenon of photobleaching, and at the same time, lengthening the amount of lengthening the cell such that it can be able to show high fluorescence if you were to shine fluorescence light at it. After auto-focusing, the image will be captured at different wavelength to show different fluorescence such that in combination, the Euro pattern is able to pick up the exact position of the cells through a combination of these mixed fluorescence patterns. Then our sophisticated analysis program will actually identify the position of exact cell through our our diagnostic sophisticated algorithm at the background to identify the position of individual exact cells. So from identification of the cells, the Euro pattern actually runs through a deeper algorithm in such whereby after identifying the cells and the substrate that is used for testing, they will also identify the parameters such as the dilution factor that is being used, which in the end will result in the reporting of the suggested endpoint dilution, endpoint titer of the antibody, which is then reported in terms of ANA pattern and as well as IFT titer pattern that's suggested to the lab user. So I've talked so much about ANA. The Euro pattern is not only available for the ANA testing, but in addition to ANA, Euro pattern actually offers one of the largest portfolio of IFA substrate that can be tested through automation software. So the other substrates that's available for Euro pattern includes our esophagus cells, kidneys, small intestine cells, granulocytes, which is often linked to the ANCA diagnosis, our nerve cells, double-stranded DNA, primate cerebrum, so on and so forth. So the Euro pattern combines it's an automated interpretation software as well as a machine. It has been compared to visual reading in a peer-reviewed article. And in this study, 351 serum was investigated using manual interpretation and as well as our Euro pattern automation suite. This study has shown that the Euro pattern can have a high positive and negative agreement up to 99.4%, and it does have a 100% sensitivity of detecting the ANA patterns with a high specificity of up to 97.5%. And at the same time, the difficult thing about identifying a pattern is that the patterns were identified using Euro pattern was that we can identify up to 94% correct identification of this pattern as compared to the manual reading. So in summary, the Euro pattern actually is Euro pattern, which is part of our ANA visualization or automation suite, is all linkable to our middleware software called the EuroLab Office. The EuroLab Office actually is able to communicate with all our different kinds of automation available for ELISA platform or immunoblock platforms, such as it allows a single channel communication with for the laboratory to our automation suite. So using our EuroLab Office, it provides laboratory management in terms you are able to do sample requests, rerun testing, calls, result consolidation, result archiving, having QC or communication with our software or the machine itself as a single platform. And everything in the EuroLab Office is compatible with the LIS system, such that it can provide a seamless integrated workflow and as well as decrease the amount of paper used for laboratory functions and workflow. So I've talked to you about how automation can actually overcome the identification of difficult patterns to pick up. The next thing I would like to introduce to everyone will be the confirmatory testing with our Euroline product. So we know that in scleroderma, we do have multiple antigens that can result in scleroderma. And however, one thing to bring about is that some of these patterns that's observed, actually the patterns that's observed do not actually differentiate what are the different antigens that's being tested for. In terms, if I were to just cover up basically the table, what we see is just patterns that's being observed. So we do know that fine speckle can be relating to multiple different kind of antibody that's being targeted. So what's important here is that more information is often required for antibody identification, such that the patient can actually know have a better diagnosis. And these data actually help with patient management. So in Euroimmun, we do recommend this strategy, whereby the first step would be always to screening with ANA screening using our head-to-cell-based biochips of technology. So from there, after the ANA screening, in the event of a positive or strong relation based on clinical symptoms, a confirmatory test or differentiation test should always be performed such that we can better identify the different antigen markers that's available. To do that confirmation or differential testing, we propose to let multi-parametric testing such as our Euroline, or in some cases, ELISAs can be used for this confirmation and differential testing. And together, all this will actually generate a results that can better that can secure the confidence of laboratory testing to the conditions. So what I'm showing here is the different profiles that's for ANA testing from Euroimmun that's available. Please do note that we do have more than the profiles that's available here. So if you do have any strong recommendation or needs, do get in touch with our partners or us, and we will be definitely more than willing to help you find the right profile that meets your need. One thing to take note is that in Euroimmun's Euroline profile, all our profiles are actually multi-parametric. We only need minimal sample requirement to run this test, and at the same time, all these profiles can be automation compatible with our hardware, automation hardware if there's a need to. Some basic test principle of how this Euroline actually works is that antigens are actually being spotted onto the line our Euroline profile test strip itself. In the presence of autoimmune antibody that's being dictated by this dark green antibody, we will seek out the antigen and bind to it. A secondary antibody will then be incubated, whereby colors change and will be shown. With the positive detection of autoimmune antibodies, this is then run through our proprietary software of our Euroline scan, whereby we can help you semi-quantitate the amount of antibody present in a patient's serum and call the results either in a semi-quantitative format of up to 3+, or in a negative format. So back to my example of increasing the diagnostic sensitivity from IFT screening for autoimmune testing. Basically, if you look at myositis for a case study, if you just bring out IFT screening may only account for 61% of diagnostic sensitivity. The reason is due to we do know that myositis do have many different kinds of antigens that can result in myositis, the disease from developing. However, one thing to know is that not all antibodies will result in an observable pattern on helper cells. Some of these antibodies that do not result in a pattern are your MDA5, your SAE1, HMGCR, SRP, so on and so forth. Therefore, it's important that we identify these markers based on other kind of diagnostic methodology that is available. Hence, Euroline can detect autoantibodies that may not be able to be identified through IFT screening. So I've talked about Euroline on autoimmune diagnosis for ANA. These are some other profiles that's available for autoimmune diagnosis, which can include your vascular disease, your autoimmune liver testing, so on and so forth. At the same time, our Euroline assays are not only just for autoimmune testing, but we do have infectious portfolio, infectious Euroline that's available. More recently launched will be our Euroline for testing of our COVID-2 SARS detection, and as well as the differentiation of other human coronaviruses. And one thing to remind is that all our Euroline is compatible with our automation software. And what I've shown here is our Euroline Blot 1, whereby automated pipetting, sample incubation, as well as scanning and result interpretation is all done using this instrument. So in summary, the Euroline actually does have a lot of advantages. The benefit of Euroline for laboratory is that it can actually help increase in diagnostic sensitivity in combination with our IFT. At the same time, multiplexing with Euroline does have high sensitivity as it can prevent the miss out of certain autoantigen or an antibody that's in the serum itself. At the same time, it's able to differentiate the autoimmune antibody that's in the sample because of the multi-parametric testing algorithm that we have here. Last to know, with all laboratory, this only requires minimal sample volume, so we can actually co-share these samples, serum samples from the IFT screening with the Euroline testing. So in summary, Euroimmun, to recap Euroimmun's proposed strategy, when a patient does have an autoimmune disease suspicion, we will recommend that ANA screening should always be done on the first test using the HEP2 cell for IFT. And if there are technical challenges behind the testing of ANA reading patterns or understanding the patterns, automation is a solution that can help overcome these technical difficulties. If there are clear, if it's clear negative for ANA along with the clinical correlations, that we do know that there may not be an additional antibody testing that is recommended. However, if the clinician do suspect that that there may be changes downstream, maybe in the 3 to 6 months, monitoring may be called by the clinicians, such as repeat of this test can be done at a later stage. However, if let's say in the event whereby there's a positive screening from ANA IFT, or if the clinician do suspect that there are clinical symptoms that's available, however, it might be a limitation on IFT, a confirmation test or differentiation test using a monospecific or in our case, a Euroline can be done for this to firm up the results, such that we can actually provide a higher confidence and better security for reporting of results. So once the confirmatory results through Euroline and IFT screening is out, this in combination can be correlated to the clinical symptoms, such that the clinicians can have a higher confidence of diagnosing autoimmune disease in the patient.
Mr. Yu, there is 3 minutes left.
Okay, I'll just go on. So in recap, the gold standard of ANA testing is to do IFT, and at the same time, HEP2 cells can actually, HEP2 cells is required for this IFT. And what I've shown is that using our Euroline monospecific test, we can actually help in increasing this diagnostic sensitivity, and as well as using automation, we can overcome some infrastructure challenges. We do know that in laboratories, quality results is important. Hence, in Euroimmun, we have an array of holistic training program that's available, and as well as our quality assessment scheme, and as well as external quality program that can help in this testing and improving our quality results for the laboratory. In lieu of short time, I will just bring your attention to our proficiency testing. We do know that in proficiency laboratory quality management, data is important, and it requires assessment to identify where are the flaws of different labs. So WHO do recommend that laboratories do go for some form of assessment to understand their work processes, pick up bigger points in the laboratory. And also, this is also recommended in American College of Rheumatology recommendations, whereby laboratory should participate in an appropriate quality assurance activity. So, in short, I would like to just bring your attention that Euroimmun actually do have our own external quality assessment scheme that's available. This happens twice a year, and there's more than the participation of this EQA assessment is joined by more than 40 different countries. Our EQA do not just focus on autoimmune related testing, but at the same time, we do have infectious serology and as well as allergy testing should there be a need. So in short, I will thank you for your attention, and I'm willing to take any questions that you may have for my presentation.
Thank you, Mr. Ye, for the interesting and very important presentation on how standardization and quality in the testing is very important. And please text your question in the chat room. There is one question from Dr. Agus Setiawan. Since there is subjectivity in ANA in immunofluorescence, is that ANA profile better than NIF?
As what I've mentioned previously in my slides, I think that a combination of IFT as well as ANA profile actually increases the diagnostic sensitivity, such that clinicians can have higher confidence to help in patient management as well as patient treatment. Yeah, so we always need to do it in a combination phase.
Is there any possibility in ANA-IF to get unspecific pattern and how to report it?
So linking back to the previous point, you see, I mean, if let's say there is a suspicion of unspecific pattern that is being reported, using secondary methodology such as a monospecific test, in Euroimmun's case, the Euroline, we can actually help identify and eliminate these unspecific patterns through this confirmation testing of Euroline testing.
Thank you, Mr. Rie. There is another question from Christina Sanjaya from Prodia. How to accurately differentiate seronegative rheumatoid arthritis, recent onset rheumatoid arthritis, and inactive rheumatoid arthritis?
Sorry, can you repeat?
How do you accurately differentiate seronegative rheumatoid arthritis, recent onset rheumatoid arthritis, and inactive rheumatoid arthritis? Maybe Dr. Jasmin can help also.
Okay, so we actually, both can have the same clinical manifestation, both seronegative and seropositive rheumatoid arthritis. So, in terms of clinical manifestation, it may not differ much, but those who have seropositive, sometimes they are more aggressive. If you do an X-ray or an ultrasound, probably you see a more erosive and a quicker erosions compared to those with seronegative, which is a more slow, it's a more insidious onset compared to those with seropositive. But sometimes clinically we are not able to tell, but in some cases, again, different patients will have different patterns. It depends on the individual, how fast, how abrupt, how insidious is the progress of the arthritis goes. And yes, but those with anti-Ccp or rheumatoid factor positive, as I mentioned the difference earlier, they can have more damaging and more active and more frequent flares probably.
Mr. Rie, thank you, Dr. Jasmin, for the question answer. Mr. Rie, there is a question. Lab should specify the method and result semi-quantitative according to American College of Rheumatology, and also they should mention also the method. How do you think we can compare between method by reporting the method and for the physician to compare the result if we mention the method or the result semi-quantitatively? Is there any standardization in the method itself?
Okay, based on the American College of Rheumatology, what they did mention is that the laboratory should do some form of validation testing if they were to use other monospecific or other tests apart from IFT. However, based on what we offer in Euroimmun, and we think that it increases the best sensitivity, we should always use an IFT as we follow the PCR guideline. We should always use IFT as the first line of screening. We do, and at the same time, if let's say it's positive, then we will follow it up with our Euroline testing, such as we do to prevent any miss out, any markers that's actually available in the patient.
Okay, thank you. Since there is subjectivity in ANA-IF, is ANA-IF profile better than ANA-IF? There is many questions regarding this one.
I think that, actually both of them should be done together. We should always follow a certain guideline whereby the ACR proposes ANA IFT first. Only as you know what is mentioned by Dr. Jasmin, that if you were to just use one, it's ANA is actually positive in some of the healthy patients, cancer, as well as patients who are infected with certain diseases. So if we use IFT, we will see a certain patterns, but we may lose out on some marker sensitivity. So if we were to use ANA profile, it actually, in combination, increases the sensitivity of diagnosis. However, saying that, we do need to know that we should always correlate this to our clinical symptoms as observed by the clinicians.
Thank you. There is one question. If NAIF negative, but NA profile strongly positive, positive 3 or 4, is it possible? How do you explain that?
Well, I mean, this brings down to the scientific part of things. There's no 100% methodology out there. If let's say in the case that you mentioned, ANA-IF is negative, while the profile is positive, what we can do is that clinicians do need to base this data and correlate it to clinical presentation that's being displayed by the patients. So in that case, it helps them with securing of the diagnosis of the patient.
Thank you. Maybe Dr. Jasmin can share from the clinical perspective. In Indonesia, some doctors test both ANA-IF and ANA profile, and they get confused because they get ANA-IF negative and ANA profile strongly positive.
Okay. Actually, I have not much of experience in it because in Malaysia, in the laboratory facilities that we have, we always send for the ANA-IF. We still haven't used the facility of the ANA, the specific ANA testing. But like what Mr. Yul has mentioned, probably this can, help to compensate. But again, we need to see this based on the clinical evaluation of a person overall, just not based on the positive blood test results, but again, going back to history, clinical findings, manifestations, and the overall picture of a patient.
Thank you, doctor. There is one question. Maybe this is for Professor Dr. Jasmin. Is there any recommendation about checking an anti-MCV comparing to anti-CCP in rheumatoid arthritis diagnosis from Dr. Hantoro Gunawan?
Okay, I believe anti-MCV is something to do with vermaline. I think this is more for research based, but in our routine clinical testing, I think what we use is anti-CCP. The first generation which was brought in was CCP1, but they didn't find it to be that sensitive. But then as the years goes on, they found I think the CCP1 is again the frigalin, but CCP2 was with better sensitivity and specificity, and now they have anti-CCP2. I think there are other anti-cyclic saturated peptide versions like the vermaline and the others, which I'm not too familiar with, but what we clinically use is, and the most available one is anti-CCP, which shows to be highly specific for rheumatoid arthritis.
Thank you, Professor, for this explanation. There are many questions, but due to time constraint, we have to end this session. Yeah, we have already 2 speakers with us, which are very experienced and knowledgeable in autoimmune disease, and we have know that autoimmune is not an easy disease, and using the marker in combination with the clinical sign and symptom is very important. A positive result doesn't mean that you have autoimmune disease, and negative result doesn't mean also that you don't have autoimmune disease. Clinical sign and symptom should be always considered. Maybe the speaker will have some final say on this.
Well, I really hope that our talk gave lots of input in your how you're going to manage the patients who you're going to see in the clinical settings when you see rheumatic patients, especially in the primary care and GPs, so that you all will understand and will not unnecessarily also order the test, but as from a physician point of view, but to treat or to diagnose a patient as a whole, just not based on lab results.
Correct. So don't overuse the test, right?
Yes.
Mr. Ye, any last say?
I was just reinforce that diagnostic of autoimmune disease is not easy, but then with the right kit and the right methodology, we can actually improve the diagnostic sensitivity such that patients can always have the highest quality treatment available.
Thank you so much, everybody. Thank you for participating in this session, and my sincere thanks to the Professor Dr. Jasmin and also to Mr. Ye for sharing their knowledge to us. Don't forget to follow the next session. There are still many good and informative sessions after this.